Good afternoon, everybody. I'll be talking to you on diabetic retinopathy screening challenges in the community. Much has already been said about diabetes, so nothing more to add, only I'll concentrate on the challenges. However sad it might be, India has become the diabetic capital of the world with 65.1 million diabetics. Add to that 21.5 million pre-diabetics, and AIOS had done a pan-India study and recorded the prevalence of diabetic retinopathy to be 21.7%. So coming to the screening, who, how, and whom to screen, preferably an ophthalmologist, but also a trained field level worker can do the screening, can be done with ease by indirect or direct ophthalmoscopy, but best would be by fundus photography because we can keep a documentation, and in cam settings, handheld fundus cameras does as well. Whom to screen? People with known diabetes is one approach. Next is the opportunistic screening, which is the best approach where we screen all patients attending our OPD for diabetic retinopathy, and next is the mass screening or the community screening. The current scenario in India is the on-static site, the mobile vans, as has been shown earlier, and the teleophthalmology or the artificial intelligence, as has been described by my previous speakers. So what are the challenges that our community is facing? One is lack of awareness, fear of complication. Patients are afraid, so they do not come to the eye doctor. They say, we do not have any eye problems, so why do we need to see an ophthalmologist? Some misconceptions. Treatment delay, because most of the diabetic patients know when they start the treatment, they have to keep on continuing it lifelong, so they want to delay it. Socio-economic status is one daunting problem that India faces, and of course, poor educational background. There are certain patient-level barriers to screening, wherein rich people also fail to come for screening camps. Those are patients having competing priorities, some anxious patients, some are disengaged patients who do not bother about their diabetic care, some misinformation, and of course those forgetful patients who plainly forgot to come for the DR screening. We just cannot sit back and relax. We have to think about the remedial measures. Community-based outreach screening is the best way to improve that. Counseling has a good role. We have to strengthen the diabetic retinopathy services. Cross-referral between the physicians and ophthalmologists needs to be done, because whether the diabetic patient goes to an ophthalmologist or not, he definitely goes to his physician for his glycemic control, so the physician should take steps to refer it. Awareness among the paramedical staff about diabetic retinopathy needs to be raised. Public education is the most important factor where we can improve the patient's knowledge about diabetic retinopathy by educational material, enrollment forms, and public awareness talks in TV, radio, or newspapers. To conclude, we can improve diabetic retinopathy screening by integrating the screening with other diabetic care, introducing and integrating the newly diabetic cases in the screening programs. Language barrier gap needs to be breached, and the program has to be made sensitive to the different ethnicities. The screening site should be easily accessible with good transportation. Thank you very much for your kind attention.